Okay, so this is our next neuro lecture. This is a trauma lecture. It's a quick one. Just going to hit some high points here, stuff I think is testable. Starting off real quick with a comparison. This is basic, just basic review, just a refresher. We've got two head bleeds here. The orange one is lenticular shaped. Doesn't appear to be crossing suture. The red one is more crescent shaped. Definitely crossing sutures, right? It's going the whole thing. I picked one that was isodense because I think those are the tricky ones, right? But we can see that that's a different density than the brain. And there's also, we point out here that, sulci over here, and that's all effaced right on this side here. So this is subdural. So here's the testable stuff on what's different. Remember that epidurals will cross the midline, where subdurals don't. It's not uncommon to see subdural blood sort of going like that, right? You see that all the time. Epidurals will cross and won't do that. However, they will not cross a suture, and that's why they make that lens shape, because they're sort of they're hung up. They're epidural. They're outside of the dura, so those dural adhesions sort of keep them hung up. And they are arterial. This is because, a couple of things to think about with that. They're often associated with skull fractures. Middle meningeal artery injury is a classic one. And because of that, the history can be rapid expansion and death. These are more dangerous than subdurals. They're high pressure as they are arterial. Subdurals are venous, the opposite. And these tend to be, your old man or your alcoholic, somebody who has an atrophic brain, so that they've got these bridging veins. So when the head gets shook, then you end up tearing them, and they develop subdurals. And like I mentioned before, the epidural, the classic history is a skull fracture. Next case here, so we've got a bleed, and take a zoom in look, and the reason I'm showing this case is for this finding right here. This is the so-called swirl sign. So the part that's actually less dense, the black or grayer part there, is actually a site of active bleeding. It's non-clotted blood. The clotted blood is the white stuff. That's the dense stuff. So when you see white blood, which is what they teach first-year residents to look for on head CTs, that's actually like subacute blood. That's not hyperacute blood. Hyperacute blood is actually isodense. It's when it starts to clot and break down stuff that it becomes more dense. So don't forget about that one. Here's another one. So this is a scrolling case here. In a pie we're seeing there's a lot of blood here, subdural and probably maybe a epidural component as well. A lot of midline shift, that's key. And then as we move down here, there's bleeding both in the pons and the medulla that maybe isn't related to the injury that caused the blood higher up. So you may remember that this is a direct hemorrhage. Basically what's going on is you've got herniation, often in the setting of an epidural, that's causing the mesial temporal lobe to herniate downwardly through the tentorial hiatus. Now when that happens, it crushes those basilar perforators and results in hemorrhage of the medulla and pons. So it's sort of a secondary hemorrhage that's occurring in the setting of a herniation syndrome. And it's named, and it sort of sounds French, right? So that makes it high yield. Another comparative case here in the setting of trauma. Old school people like to classify temporal bone fractures as either longitudinal or transverse based on the direction of the fracture plane. Now, this is silly, right? Because reality is the majority of the time that's complex and sort of multi-directional, but you'll see lots of textbooks break them down, and there's some really excellent ways to ask multiple choice questions about this. So let's run through that. So the longitudinal one is more common. The way I remember that is sort of like if you measured them, the one that's long has more, so it's more common. Longitudinal, long, more. The other one's the other one. It runs in the plane of the ossicles. You can imagine if you had a fracture plane in that way, there'd be no way to miss the ossicles. But if you fractured it in the other direction, you could miss the ossicles. And if you have ossicle disruption, that's your conductive hearing loss, so that makes it conductive hearing loss. Transverse plane, that's sort of, if you think about the direction of the carotid is more like this, right? So it's like cutting through in that direction, so there's more vascular injury. And this is, the way I remember this is, it's the other one is the other one, so if we said that longitudinal was conductive because it hits the ossicles, then the other one is the other one, so it's more nerve issues, so sensory neuro hearing loss, and also damage to the facial nerve, which you remember runs through the temporal bone as well. So here's a practical point. It's possible it could show up on the test as well, but it's more of a practical point. These transverse and longitudinal terms are more descriptive. The thing that's more predictive for actual badness is capsular, otic capsular sparing or violation. Remember, the otic capsule is like the densest bone in the entire body. That's that really dense bone that you see in the middle of the ear. Looks really, really, really white. If that gets violated, then you've had a really major injury, and you're way more likely to have facial nerve, sensory neural hearing loss, or even a CSF leak. So it's the way more predictive, descriptive term that you can make. Okay, next point here. This is very high yield and a confusing thing. I'm going to make an effort to explain it. So we've got a T1 and a T2, both showing a subdural collection of blood, and the question is going to be, when did this happen? So you've been hired by the forensic team to date the injury, and they want to know exactly how many hours ago this person had an injury. So the paper this is actually based on is got a pretty small sample size, so this doesn't always hold up in real life, and it also, this blood age dating stuff was described only in CNS situation, that it's people that try to transfer this knowledge into the abdomen and into the legs and arms and stuff like that doesn't always hold up too, because for a variety of reasons. Obviously it's complex. So this is the graph you'll see in books. It's very complicated. People will say just memorize it. This was our case, an ISO bright case, and people have all kinds of really bad ideas as far as remembering this. One of them that's popular involves making a bunch of baby noises. I think that's stupid. I'm not in the habit of making baby noises. So this is my method for remembering it. I think it's way easier. I'm a visual learner, so I like to think visually. And also, in real life and for the test, you're given scratch paper or you're given a dry erase board or something, so you can draw this out. And then you could have it there. You draw it out and you've got it there. You can answer these questions. So if you start out here, right in the middle on the far edge, and let me explain the graph first. So we've got one axis that's T1 and the other axis that's T2. The first one that you come to is T1. Another way to remember that, so you don't get your axis mixed up, is that a 1 sort of looks up and down, so this is up and down, and then the other one is the other one. And then so black, ISO, and then bright, black, ISO, and then bright in that direction. So here we go. So this is where we start out, and so for T2 we're on the bright part, and for T1 we're on the ISO part. See that? Here and here. And that's hyperacute. And then you move into your acute phase, which is dark and ISO. Okay, so after acute, then we move to here, which is a bright dark. This is our early subacute. People often remember that T1 bright is subacute. Okay, and then late subacute. And then chronic. And then sometimes chronic has a sort of ISO or bright center to it. So basically what we're doing is you are drawing that sort of a clockwise circle. If you can just, it's remarkably easy to remember if you draw it out. And you may look at this and say, this looks complicated. I just want to make the baby noises. Fine, make your stupid baby noises if you want, but before you do that, just try drawing it one time, and then you can thank me when you get it, when you realize how much easier it is to do this way, and you can get the questions right on the test. So yeah, if you can draw a spiral with a clockwise direction, you can. That's all you need to do. Boom, you've just remembered it. Just take the time to draw it out, and you have the time to draw it out, and you'll have something to draw it out with. And then once you do it, like for practical purposes, just remembering that the one that's T1 bright is subacute, and the one that's not T1 bright but is also T2 bright, so in other words, the ISO T1 bright T2, that one's the hyperacute one. And if you've got that, then you pretty much got it done. Or you can just Google it every time. That's what a lot of people do, even people that are neuro attendings, just look it up, because it doesn't come up that often, honestly. But for the test, draw the spiral. Alright, so moving on, next question here. So we've got a diffuse subarachnoid hemorrhage, showed a bunch of cases of this in the vascular module. The question I've got here is, what is the most sensitive MRI sequence? So T1, T2, diffusion, SWI, or flare. Now, if you remember, flare works by it's an inversion. It's an inversion type of sequence, and what it nulls is CSF. So anything that's not CSF doesn't get nulled. Blood is not CSF, so blood doesn't get nulled. So instead of being dark, it's very bright. It makes it easy to see subarachnoid hemorrhage. Now, there are several artifacts or fake outs that can make things look like subarachnoid hemorrhage that aren't on flare. And I'm going to go over the ones that I think are most common. So here we've got some, what somebody might call subarachnoid hemorrhage right here, right? But if we look at the diffusion, then we see that there's some kind of artifact like you see with metal, like a valve, or it's the same kind of stuff that you see with dental artifact. So metal disrupts the field homogeneity and results in incomplete nulling of CSF. So that's a really common one. Another common one is inhaled oxygen therapy can cause flare signal abnormality. Infection like subdural empyema or whatever can look like blood, because it's not, again, it's not CSF, right? And then the last one to remember is propofol is another thing that can create a high flare signal and mimic subarachnoid hemorrhage. All right, so we've got coronal and axial hemosiderin sensitive sequences, and we're seeing these foci of low signal within the deep white matter buzzword and along the posterior corpus callosum. That's a buzzword also. So in the setting of trauma, this is going to be diffuse axonal injury. So some people say it's from shearing or stretching. Well, that doesn't really matter. The mechanism's actually controversial. The thing to remember that it involves the deep subcortical white matter, the posterior corpus callosum, and basal ganglia. Just by the supposed mechanism, it tends to favor the more deep structures. Another thing to know is that the head CT is often negative. It's a cult on CT imaging. So you can have a patient who's in a bad motor vehicle or accident or high velocity, high speed trauma, get a head CT, it's normal. Clinical history is that they're obtunded or they're in a, quote, coma. And it's like, oh, that's weird because it looks really negative. Yeah, that's because he has bad DAI. And then you get the follow-up MR, and this is what you see. All right, so next case, this person's had a bad smash to the face here, nasal orbital ethmoid pattern where the nose and things are just sort of crushed backwards. So what is he set up for? So let's review real fast normal sinus anatomy here. So here's your frontal sinus draining into your ethmoid sinus, and it drains through a little thing here, that little passageway right there. Some people call that frontal ethmoid recess. So if you can imagine that in this setting where somebody's had their face crushed and that thing disrupted, that it's going to later on affect your ability to drain your frontal sinus. So if you can't drain the mucus out of your frontal sinus, then you end up with a mucocele. So some buzzwords here, an important one: airless expanded sinus. This one's a sphenoid sinus mucocele. It's usually T1 bright and can have enhancement that's more peripheral. The frontal sinus is actually the most common location, and as noted, it occurs secondary to trauma, like disruption of that drainage pathway. So ENT likes to know if that frontal sinus drainage pathway has been disrupted, because they will go and enucleate that frontal sinus or do something to it so that you don't develop a mucocele. All right, another trauma case. Just going to point out some findings here. First, I'm going to give you the buzzword, pulsatile exophthalmos. So that's a buzzword that's specific for this entity. You can also see it in NF1 with the sphenoid wing abnormalities. They supposedly can also get pulsatile exophthalmos, but in a setting of trauma, this is a dead giveaway. So when I say pulsatile exophthalmos, you need to first look here and say, oh, he does indeed have exophthalmos, just subtle, but he has a little bit. And then the next thing I look at is the cavernous sinus. Notice it's asymmetric there on the right. It's larger on one side than the other. And then they're strangely showing me a cut that's a little bit higher up and showing me a prominent superior ophthalmic vein, which you're not really seeing on the other side. So that is a finding that is seen with a carotid cavernous fistula. Now, there are two types. Of course, this is all testable. The ones that you most commonly think about are the one like I showed, which is the direct type. So what does that mean? Well, it means you have a trauma, and then you get a communication between the cavernous sinus and the intercavernous ICA. There's also another type that's the, quote, indirect ones, and these are the ones that are seen in just random postmenopausal women develop them, and it's a communication, again, between the cavernous sinus and this time the external carotid artery through a branch of the meningeal branch. So, all right, moving on. This guy here, that's a face only a mother could love. He's had a bad face smash, and the question would be, what kind of Lefort fracture does he have? Now, modern trauma, it's, Lefort was developed, some medieval guy throwing skulls off a castle wall or hitting them with clubs. Most trauma that occur today are from car wrecks, right? So it's different mechanism than getting hit with a club or having your head thrown off a castle wall. So it's medieval, it's outdated, it's a stupid classification system, and as a result will likely end up on your test, the quote test of the future. So here are your Leforts. I'm going to run through some buzzwords. The first one, Lefort 1 is sometimes referred to as a floating palate because of where the fracture plane occurs. A number 2, or Lefort 2, is sometimes referred to as a maxillary facial separation, where the maxilla is separated from the face. Sometimes it's also referred to as a pyramidal fracture because it sort of looks like a pyramid, or a triangle. And then the last one, which is a 3, is sometimes called cranial facial separation for the same one. You can imagine that's worse. So palate 1, maxilla 2, face 3. So how do you get these things straight? It's really complicated. You look them up in a book, and there's 100 different things that they describe on each one. So I'm going to make it real simple. All Lefort fractures have one thing in common. They all involve fracture of the pterygoid process. These are the flimsy little things hanging off the back there. All Lefort fracture. If you don't have a fracture of the pterygoid process, you don't have a Lefort fracture. And then there's unique fracture points for each one. So type 1 has got fracture of the lateral nasal aperture. 2 has got fracture of the inferior orbital rim or floor. And then 3 has got a fracture of the lateral orbital rim or floor / zygomatic arch. So let's take another look at that. So 1 has a fracture here, right here. That's the lateral nasal aperture. 2 is the inferior orbit, see that? And then 3 is the lateral orbit, or the zygoma. Anyway, if you can remember this picture right here, plus the fact that the pterygoids are involved in all 3, then boom, that's all you need to know to answer them. Okay, so this is the last case, and it's just to remind you that non-accidental trauma can be shown with a brain MR. So we've got a kid here with subdurals, and I'll point out that they are of different ages. Notice that this one's isodense and this one's got some bright stuff here. So remember, it's actually abnormal for kids with accidental trauma to develop subdurals under the age of 2, especially if they're of mixed density or different ages. Unexplained complex occipital skull fracture is worrisome. I don't care what the mechanism of injury is, that's an injury, like a slamming type of injury that is supposed to be seen with non-accidental trauma. Now there's this idea of a bobblehead, where you've got infants that lack head control, very young situation where they actually get cervical medullary contusion and become apneic, and they don't actually get subdurals, they get cervical medullary injury. But don't worry about that. That's more of a real-life pearl for the purpose of the test. Think subdurals, especially subdurals of different age in pediatric situation, or if they show you blood in the orbits, like orbital blood, then that's another thing to think about for non-accidental trauma. All right. The next lecture is a lecture on CNS infections, so that's coming up next.